Hello, my name is Jason Allen. I'm the Director of Investigations for DIDD. For over a year now, DIDD, TennCare, MCOs, and stakeholder group of 1915C Employment and Community First Choices and Choices providers have been working collaboratively to develop an aligned reportable event management system for all home and community-based services and services provided in intermediate care facilities for individuals with intellectual and developmental disabilities. The REM system was designed to enable persons supported to be the driving force in the supports they receive, while also giving providers a less burdensome, clear, and comprehensive approach to the reporting and resolution of reportable events. It is important to note that the new REM system will encompass all HCBS programs and ICF-IID. The one aligned system will allow for all reports of reportable events to be captured on one reportable event form for ECF choices, 1915C waiver, Katie Beckett, and ICF-IID programs. All direct care staff will receive additional training regarding the completion of the REF form from the DIDD Event Management Group through Elias. The REM system aligns with the Dignity of Choice protocol, which we'll get more into later in this training. The REM alignment training for direct care staff is designed to ensure that the staff providing support to persons supported have the tools necessary to identify what is reportable, properly report all reportable events, understand the definitions related to the REM system, understand allegations that would result in a Tier 1 or a Tier 2 investigation, and direct care staff's role within the investigative process. Understand due process rights for substantiated staff, utilize risk mitigation strategies related to the dignity of choice. Direct care staff are the first line of contact for persons supported and are a vital partner in identifying abuse, neglect, and exploitation. With that said, this training was designed with direct care staff in mind to better identify how this new system will enhance the lives of those we support, while also providing direct care staff with a more aligned and comprehensive reporting system. Let's start with what's reportable. In HCBS and ICF-IID programs, there are three categories for reportable events: Tier 1, Tier 2, and additional reportable events and interventions. The type of reportable event dictates the reporting requirements and process that must be followed by the provider, MCO, and DIDD as applicable. DIDD shall triage all allegations reported via the abuse hotline within 2 business days unless pending results of the medical assessment, laboratory test, expert opinion, etc. to determine the need for an investigation.
Tier 1 reportable event shall mean the alleged wrongful conduct affecting the person by acts or omissions of abuse, neglect, exploitation, or misappropriation of money or property that resulted in one or more of the following consequences to the person: death, serious injury, or physical harm, physical or sexual abuse, significant pain, intimidation, or mental anguish that required medical intervention, or loss of funds or property greater than $1,000 in value. Tier 1 reportable events must be reported to DIDD Abuse Hotline at 1-888-633-1313 as soon as possible, but no later than 4 hours after the occurrence of the event or discovery thereof. An REF is submitted by the Event Management Coordinator to the DIDD Event Management Unit at Central Office within 1 business day. Tier 1 investigations will be conducted by a DIDD investigator and will follow the current investigative process for allegations of abuse, neglect, and exploitation. Let's talk about an example of what is and what is not considered to be a Tier 1 event. Virginia's parents gave her a necklace valued at $1,200 for her birthday on October 1st. On October 13th, the necklace was discovered missing from Virginia's jewelry box. Virginia said she last wore the necklace on October 10th and has not seen it since she put it away in her jewelry box that night. As the value of the necklace exceeds $1,000 in value, this would be considered a Tier 1 event. Conversely, Virginia's parents gave her a necklace valued at $275 for her birthday on October 1st. On October 13th, the necklace was discovered missing from Virginia's jewelry box. Virginia said she last wore the necklace on October 10th and has not seen it since she put it in her jewelry box that night. As the value of the necklace does not exceed $1,000, it would not be a Tier 1 event. It is important to note that while the necklace in the second example does not meet the criteria for a Tier 1 event, it does meet the requirement for a Tier 2 event in that the value exceeds $250. Now let's look at an example of a Tier 1 event related to physical abuse. Person-supported James was exhibiting a challenging behavior and pushed his staff Melody to the ground. Melody got up and struck James in the face, causing a laceration just above his left eye. James was taken to the ER where he received 4 stitches to close the wound. As James required medical treatment at the ER for his injuries, this would qualify as a Tier 1 event. Conversely, let's look at an example of physical abuse that does not rise to a Tier 1 event. Person-supported James was exhibiting a challenging behavior and pinched his staff Melody on her left arm. Staff Melody pinched James in retaliation, causing a bruise on his right arm. James yelled ouch, however, he suffered no other injuries other than the bruising, which did not require medical treatment. It is important to note that for an allegation of abuse or neglect to rise to a Tier 1 investigation, the person supported must have received medical treatment by a medical professional beyond that of first aid that could be provided by a lay person. This means that if the medical professional treats the person for first aid, this would not constitute medical treatment for this application.
Let's discuss the difference between treatment versus assessment. If the person supported was assessed or monitored by a medical professional but no treatment was rendered, this would not rise to a Tier 1 investigation. As an example of assessment versus treatment, person supported Danny ingested a small amount of hand sanitizer and was taken to the ER as a precaution. While at the ER, the attending physician admitted Danny for observation. However, after a couple of hours, he was released and no medical treatment was rendered. As such, this would be considered an assessment and not medical intervention. Tier 2 shall mean the alleged wrongful conduct affecting the person supported by acts or omissions of abuse, neglect, exploitation, or misappropriation of money or property, and resulted in one or more of the following consequences to the person supported: intimidation or mental anguish, probable risk of serious harm, loss of funds or property equal to or less than $1,000 in value, or prescription-controlled medications regardless of value, or through supervision neglect harming a citizen in the community or engaging in criminal acts resulting in arrest and confinement. The person supported did not require medical intervention or treatment and is not at continued risk of serious harm. Notice is given to the provider EMC and administrator, and a ref is submitted by the EMC to the DIDD Reportable Event Management Unit at Central Office within 1 business day. Tier 2 investigations will be completed by a certified provider investigator. This is a staff that has gone through the provider investigations training, which is offered by the state. DIDD would only investigate a Tier 2 event in the case where a provider does not meet the requirements necessary to conduct their own investigations, or the investigation is too complex or involves agency management, which would necessitate that DIDD conduct the investigation to ensure a sound conclusion is reached. Let's now look at an example of what is and what is not considered a Tier 2 reportable event. It was reported that DSP Charlie Dickens punched person-supported Mark in the left arm when Mark called him a derogatory name on October 13, 2020. There was no reported injury to Mark and he did not require medical treatment. As this event did not require medical intervention, this would be classified as a Tier 2 event. In another example, it was reported that DSP Charlie Dickens pushed person-supported Mark down in the driveway when Mark refused to go inside his home on October 13, 2020. Mark was later diagnosed with and treated for a fractured left hip. This is considered a Tier 1 reportable event because Mark's treatment required a medical professional and was beyond first aid that could be provided by a lay person. Let's talk about additional reportable events and interventions. Additional reportable event shall mean a reportable event which is not related to abuse, neglect, or exploitation that the provider, MCO, or FEA staff shall be responsible for reporting to the MCO and/or DIDD as specified in the Reportable Event Management Protocol. Additional reportable events include a reportable medical event shall mean an event that occurs during the delivery of services or discovered during the delivery of services outside of a diagnosed chronic condition, which requires assessment and treatment in an emergency room or urgent care facility. It is not a reportable event when the assessment and treatment result from a medical event occurring outside of the provision of services, nor when referred to the emergency room for assessment by the primary care provider. Important to note, chronic condition shall mean human health condition or disease that is persistent or otherwise long-lasting in its effects, or a disease that comes with time.
The term chronic is often applied when the course of the disease lasts for more than 3 months. Let's now look at an example of what is and what is not a reportable medical event. Person-supported Mark was admitted to Baptist Hospital on October 13, 2020 with a diagnosis of pneumonia after his staff had noted that he was running a fever and seemed lethargic while eating breakfast. As the event was discovered during the time the person was receiving services and, by definition, was not noted as being a chronic condition, this would be considered a reportable medical event. Likewise, person-supported Mark goes to the PCP due to swelling in his legs. The PCP sends Mark to the ER for an X-ray as her office does not have the equipment needed to fully diagnose the injury. At the ER, Mark receives an X-ray that confirms he has a broken femur that requires surgery. As the injury is such that a treatment cannot be provided by the physician, then it is reportable. Let's now look at a non-reportable event. Person-supported Mark was sent to his PCP as his peg tube was dislodged as a result of him pulling on the tube. The PCP referred him to the ER to have it reinserted. As this was general maintenance from a pre-existing condition, this would not be considered a reportable medical event. A reportable behavioral event is an event in which a person presents challenging actions which requires the use of a behavior safety intervention or a restrictive behavioral procedure that is not captured as an appropriate response in the plans of care that pertain to that person. A reportable psychiatric event is an event in which a person presents evidence of psychiatric destabilization which requires the use of a psychiatric intervention or crisis services that is not captured as an appropriate response in the plans of care that pertain to that person. Important to note, the following events are also considered reportable behavioral psychiatric events, even if they do not require the use of behavior safety intervention, restrictive behavioral procedure, or crisis services. Engagement with law enforcement, property destruction exceeding $100, psychiatric admission, sexual aggression, and suicide attempt. Let's now look at an example of what is and what is not considered to be a reportable behavioral event. Person-supported Mark became upset about his mother canceling his home visit and ran towards his housemate in an attempt to attack him. Staff Charlie Dickens used an approved CPI physical intervention to prevent Mark from injuring his housemate. As the staff utilized an approved restrictive behavioral procedure to ensure the safety of the housemate, this would be a reportable behavioral event. Conversely, person-supported Mark became upset about his mother canceling his home visit and cursed at DSP Charlie Dickens. Per Mark's behavior support plan, DSP Dickens ignored Mark's behavior and did not make eye contact with Mark. As the staff was able to de-escalate the challenging behavior by utilizing a technique listed in Mark's behavior support plan, which is captured as an appropriate response to his plans of care, this would not be considered a reportable behavioral event. Now we will review what is and what is not considered a reportable psychiatric event. Person-supported Mark became upset about his mother canceling his home visit and exhibited a self-injurious behavior by intentionally cutting himself, which required stitches. As Mark's self-injurious behavior required treatment from a crisis service, in that he required treatment by a medical professional beyond first aid that could be administered by a layperson, this would be considered a reportable psychiatric event. Conversely, person-supported Mark became upset about his mother canceling his home visit and requested his PRN psychotropic medication to help him calm down and avoid escalating behavior that could result in a reportable psychiatric event. As no psychiatric intervention or crisis services were needed to de-escalate the situation, this would not be considered a reportable psychiatric event. However, this would be reported as a reportable intervention, which will be discussed later in the training. Reportable intervention shall mean a measure taken to promote the health and safety of the person which is not related to abuse, neglect, or exploitation, that the provider, MCO, or FEA staff shall be responsible for reporting to the MCO and/or DIDD as specified in the Reportable Event Management Protocol. Other additional reportable events are events that are not related to A&E, but examples of these types of events do not appropriately fit under the reportable medical, reportable behavioral, psychiatric, or reportable interventions. It is important to note that the definition for abuse, neglect, and exploitation have not changed with the new REM system as they come from the Tennessee Code annotated. However, keep in mind that for allegations that rise to a Tier 1 reportable event,
The person must have sustained an injury that resulted in medical intervention or treatment. For example, a staff repeatedly striking the person supported with a closed fist which results in a broken nose shall be reported as a Tier 1 reportable event and shall result in the Tier 1 investigation for physical abuse. However, it would not necessarily be considered physical abuse if a staff's reflex was to prevent the person from eating something inconsistent with their dining plan or an inedible object by smacking, striking, or hitting someone's hand without such force as to cause physical harm. While staff's actions were inappropriate, it would not rise to the level of a Tier 1 reportable event or a Tier 1 investigation. This would be appropriate for a Tier 2 reportable event.
Abuse means the knowing infliction of injury, unreasonable confinement, intimidation, or punishment with resulting physical harm, pain, or mental anguish. Abuse of all forms is a knowing and willful act. Mental anguish shall mean significant psychological distress that is intense or persistent and may include fear, anxiety, stress, humiliation, depression, trauma, or grief. In order to be considered mental anguish, the psychological distress experienced must be intense or persistent and linked to the actions of the alleged staff. This includes instances of intentional abuse that would result in such mental anguish in a reasonable adult regardless of age or disability.
The REM system recognizes three subcategories of abuse. Physical abuse shall mean actions including but not limited to any physical motion or action by which physical harm, pain, or mental anguish is inflicted or caused. It includes the use of unauthorized, restrictive, or intrusive procedure to control behavior or punish. Corporal punishment, takedowns, prone, and supine restraints are prohibited and considered abuse. Sexual abuse shall mean any type of sexual activity or contact with sexual intent or motivation between a person supported and anyone affiliated with the IDD as a staff person, employee, contracted provider, or volunteer. This includes but is not limited to actions by which a person is coerced into sexual activity, exposed to sexually explicit material or language. Sexual battery by an authority figure as defined in the Tennessee Code Annotated is also considered sexual abuse. Sexual abuse occurs whether or not a person is able to give consent to such activities.
Now let's look at an example of what is and what is not considered sexual abuse. It would be considered sexual abuse if a staff brought pornographic material to watch while on duty and watched it in the presence of a person supported who has restrictions regarding such material and possibly a history of engaging in criminal behavior with others in a sexual manner. It would not be considered sexual abuse for a staff to take a person supported who has no restrictions involving sexually explicit material, is known to routinely watch such material with the full knowledge of provider personnel and the expressed informed consent of the person supported to purchase sexually explicit material. Any sexual contact between a person supported and staff would be considered sexual abuse and would require contact to DIDD's abuse hotline, submission of a Tier 1 REF, and initiate a Tier 1 investigation regardless of consent.
Emotional psychological abuse shall mean actions including but not limited to humiliation, harassment, threats of punishment or deprivation, intimidation, or demeaning or derogatory communication, whether they be vocal, written, or gestured, directed to or within the eyesight or audible range of the person supported.
Now let's look at some examples of emotional psychological abuse. Telling a person supported that he is worthless, cannot do anything, and can just sit in his own urine, which causes the person supported to begin to cry and exhibit a challenging behavior, would be an example of emotional psychological abuse. To meet this definition, however, the person supported does not have to respond in an emotional or distressed manner. For example, telling the person supported that they must beg or perform in an undignified manner in order to receive an item, or telling a person supported that you are going to beat them or making physical gestures of striking a person in a threatening manner. If a reasonably prudent person would have experienced humiliation, intimidation, or demeaned by such conduct, the threshold for this definition is met. This is established in the interview process of witnesses' response should they have been the victim of the alleged action. Telling another staff person a person supported never bathes when the person supported is in his or her own room and cannot hear the comment would not be an example of emotional psychological abuse.
Neglect shall mean the failure to provide goods or services necessary to avoid physical harm, mental anguish, or mental illness, which results in injury or probable risk of serious harm. For the purpose of tracking and training, the following internal subcategory definitions of neglect are: training neglect, failure on the part of the trainer for any person responsible for providing a service that has not received, obtained, or been afforded with the necessary training to fulfill those responsibilities that resulted in or placed the person supported at probable risk of serious harm. Here are some examples of what is and what is not considered training neglect. Staff Dickens and Mark are at a ball game and Mark asks for a hot dog. Staff Dickens buys Mark the hot dog and gives it to him directly. Mark chokes while eating the hot dog. Staff Dickens and a bystander perform the Heimlich maneuver and accidentally break one of Mark's ribs in the process. Staff Dickens has not been trained on Mark's PCSP or mealtime instructions, so he was unaware that Mark's food has to be cut into half-inch pieces due to Mark's history and risk of choking. As the staff had not been properly trained on Mark's dining plan, this would be considered training neglect. Conversely, Staff Dickens and Mark are at a ball game and Mark asks for a hot dog. Staff Dickens has been trained on Mark's plans of care and his mealtime instructions, which states that Mark's food should be cut into half-inch pieces. However, Staff Dickens gives Mark the whole hot dog anyway. Mark chokes on the hot dog, requiring the use of the Heimlich maneuver, which resulted in Mark sustaining a broken rib. This is not training neglect, as Staff Dickens had been properly trained but did not follow the plans of care. This would instead be considered treatment neglect. As both examples resulted in medical intervention and presented a probable risk of serious harm to the person supported, both would be considered a Tier 1 event. Treatment neglect shall mean failure to provide specified care to a person supported that either resulted in or placed the person supported at probable risk of serious harm. Let us now look at some examples of what is and what is not considered treatment neglect. Mark and Staff Dickens are at a ballgame. Mark needs to use the restroom. Mark's PCSP states that he requires staff assistance while using the restroom and requires staff to accompany him to the restroom in the community. Staff Dickens allows Mark to go in the restroom alone and waits for Mark outside. Mark has been in the restroom for a while, so Staff Dickens enters and discovers that Mark has fallen and injured his leg. This is considered treatment neglect, as Mark's plans of care were not followed at the time of the fall. Conversely, Mark and Staff Dickens are at a ballgame. Mark needs to use the restroom. Mark's PCSP states that he uses the restroom independently and does not require staff to accompany him to the restroom in the community. Staff Dickens waits for Mark outside of the restroom. Mark has been in the restroom for a while, so Staff Dickens enters and discovers that Mark has fallen in the restroom. This is not considered treatment neglect, as Mark's plans of care were followed at the time of the fall.
Communication neglect shall mean failure to convey critical or vital information that either resulted in or placed the person supported at probable risk of serious harm.
Let's now look at an example of communication neglect. Staff Dickens takes person-supported Mark to a dental appointment on October 9th. During the appointment, Mark is scheduled for outpatient dental surgery requiring sedation on the morning of October 10th. Staff Dickens is informed and given pre-operation instructions stating that Mark should not eat or drink anything after midnight prior to the surgery. Staff Dickens fails to inform anyone else of the instructions and accidentally leaves them in the car. When the third shift staff wake Mark up for the morning, they prepare breakfast for Mark as usual, not knowing that Mark has a dental appointment scheduled for the day. Mark eats breakfast and is dressed for the day before Staff Dickens arrives for work. At the dental appointment later that morning, Mark gets sick due to the anesthesia and chokes during sedation. This was a result of communication neglect, as Staff Dickens did not relay Mark's pre-operation instructions regarding not eating after midnight. Now let's look at an example of what would not be considered communication neglect. Staff Dickens takes person-supported Mark to a dental appointment on October 9th. During the appointment, Mark is scheduled for outpatient dental surgery requiring sedation the morning of October 10th. Staff Dickens is informed of and given pre-operation instructions stating that Mark should not eat or drink anything after midnight prior to the surgery. Staff Dickens calls the home manager to relay the instructions, posts the instructions on the refrigerator at Mark's home, and calls the third shift staff to let them know that Mark does not need to eat or drink anything after midnight. When third shift staff wake Mark up for the morning, they prepare breakfast as usual, forgetting that Mark is not supposed to eat or drink anything that morning. At the dental appointment later in the morning, Mark gets sick due to the anesthesia and chokes during sedation. This is not communication neglect, as the instructions were properly communicated to the third shift staff, who simply failed to follow them. Supervision neglect shall mean failure to provide adequate supports that resulted in harm or probable risk of serious harm. Now let's look at an example of what is and what is not considered supervision neglect. Person-supported Mark has a history of eloping from his home, and his PCSP states that he must have awake staff around the clock for this reason. Staff Dickens falls asleep during the third shift and does not hear or see Mark walk out the front door at 2 a.m. When Staff Dickens wakes up around 3 a.m., Mark is nowhere to be found. This is supervision neglect, as Staff Dickens' failure to ensure adequate supervision led to Mark becoming a missing person and placed Mark at probable risk of serious harm. In another example, person-supported Mark has a history of eloping from his home, and his PCSP states that he must have awake staff around the clock for this reason. Mark gets out of bed and walks out the front door at 2 a.m. Staff Dickens follows Mark out. Staff Dickens calls the home manager to let him know what is going on. Mark walks around for a while with Staff Dickens following behind him to intervene if there is danger. Mark takes off running and Staff Dickens cannot maintain visual contact and loses Mark. This is not supervision neglect because Mark's plans of care were followed and staff was awake to respond to the elopement. Exploitation shall mean actions including but not limited to deliberate misplacement, misappropriation, or wrongful, temporary, or permanent use of belongings or money with or without the consent of the person receiving services. The illegal or improper use of the person's resources or status for another's benefit or advantage is considered exploitation. For tracking and trending, the following internal subcategory definitions are financial, misplacement, misappropriation, or wrongful, temporary, or permanent use of the person's supported funds. Exploitation, the illegal or improper use of the person's resources, property, or status for another's benefit or advantage is considered exploitation. Let's now look at some examples of exploitation. An example of an allegation of exploitation, financial, could involve a support staff taking the spending money of the person supported from the home. Per the same scenario, it would be an example of exploitation should the support staff knowingly take a gaming system belonging to the person supported in order for the staff to play games on his or her personal time. Additional examples include staff posting to Facebook the person engaging in challenging behaviors for personal gratification, using the person's disability to gain access to events in which the person has no expressed desire to attend, using the person to obtain free items in which the staff takes possessions of. These are examples of the staff's use of the person supported for personal gain. Now we will take a look at what is not considered exploitation. Should staff forget, without intent, to return the change received when on a community outing to the proper location at the end of his or her shift, but returns the money, this would not be an example of financial exploitation. Should a staff take a gaming system belonging to the person supported with the consent of the person and agency management to be repaired and promptly returned in working order, this would also not be an example of exploitation, as the property of the person supported was not taken by the staff for the personal benefit of the staff. Other allegations that would be investigated are serious injury of unknown cause shall mean an injury that requires assessment and treatment beyond first aid that can be administered by a lay person, the cause of which is unknown. If unknown or suspected to be the result of abuse and/or neglect, the serious injury shall be investigated. Let's now talk about examples of serious injury of unknown cause. Person-supported Mark could not stand up upon walking on October 13th. He was transported to the ER where he was diagnosed and treated for a broken right femur. Mark is not able to communicate what caused the broken femur, and the cause of the injury is unknown. As Mark was unable to provide a reason for the injury, nor was the event witnessed or documented by staff detailing how the injury may have occurred, which resulted in medical treatment beyond what a layperson can provide, this would be considered a serious injury of unknown cause. Conversely, Mark was not able to bear weight on his right foot on the morning of October 13th. He was taken to the ER and diagnosed with a broken right big toe. Mark said that he had stubbed his toe on his nightstand when returning from the bathroom during the night. As Mark was able to provide a detailed account of the event, which is consistent with his injury, this would not be considered a serious injury of unknown cause. Suspicious injury shall mean an injury that may have been the result of abuse or neglect, or is not consistent with the explanation provided. There must be a reason to suspect the injury was the result of abuse or neglect. Here are some examples of what is and what is not considered a suspicious injury. Person-supported Mark, who is wheelchair-bound and non-ambulatory, was discovered with 2 large bruises, approximately the size of a large grapefruit, on his left thigh and upper left leg. Mark is not able to communicate the cause of the bruises, and there have been no reported falls or any other explanation for the injuries. As Mark is wheelchair-bound, and there is no account for how the significant bruising could have occurred on an area of the body in which there would be reasonable concern that abuse and/or neglect could have played a contributing factor for the injuries, this would be considered a suspicious injury. As an example of not a suspicious injury, person-supported Mark, who is ambulatory, was discovered to have a large grapefruit-sized bruise on the front of his upper right leg. When questioned, Mark reported that he had accidentally walked into a bar stool in the kitchen. The stool is the height of the bruise on Mark's leg. As Mark was able to provide an account for the injury and was consistent with the physical evidence, this would not be considered a suspicious injury. Suspicious death shall mean a fatality occurring under circumstances that are unexpected or unexplained. All suspicious death will be reported as soon as possible, but no later than 4 hours, to law enforcement and the DIDD abuse hotline. Here are some examples of what is and what is not considered a suspicious death. Person-supported Mark, who is a healthy 60-year-old, was discovered to be deceased when his first shift staff checked on him in his bed at 7 a.m. during shift change on October 13, 2020. Mark's medical history included seizures, but no recorded seizure activity in the past year, and had not complained of any health concerns in the days or weeks leading up to his death. Mark was last seen by his PCP on February 10, 2020. As Mark had no identified morbidities preceding the staff finding him unresponsive, aside from a seizure disorder that was controlled by medications with no activity in the past year, his death would be considered unexpected and unexplained, which would be considered a suspicious death. As an example of a non-suspicious death, person-supported Mark died at 7 a.m. on October 13, 2020. Mark was previously diagnosed with cancer and had been receiving hospice care in his home for the past 2 weeks. As Mark was receiving palliative care at the time of his death, and his death could be both explained and expected, this would not be an example of a suspicious death. Medication variances and omissions shall mean a discrepancy in the medication administration process. This occurs when serious injury or harm is inflicted on a person supported as a result of improper or absence of medication administrations. The submission of categories E through I on the medication variance form shall require a call to the DIDD abuse hotline as soon as possible, but within 4 hours, and a typed report is submitted by the event management coordinator to DIDD Reportable Event Management Unit at Central Office within 1 business day. In all cases, medication administration by a person who was not trained and certified or was not licensed by the state of Tennessee to administer medications requires the completion of a medication variance form and an REF for alleged training neglect, and could be a Tier 1 or Tier 2 investigation depending on the outcomes. An example of a medication variance would be missing the administration of a medication prescribed for the diagnosis of seizure disorder. Later, the person supported experienced a seizure longer than the specified time frame, and EMS was called. The person required a visit to the emergency room. As a result of the medication administration being missed, the person supported suffered a seizure that required a visit to the ER, which, depending upon the treatment versus assessment, would dictate the classification of the event as either a Tier 1 or a Tier 2 reportable event. It would not be a medication variance if a medication prescribed for pain is to be administered every 4 hours and the medication was administered 15 minutes after the appropriate time. Here are some other definitions to be aware of. Class 1 event. The wrongful conduct affecting a person supported constituted abuse, neglect, exploitation, or misappropriation of money or property and resulted in one or more of the following consequences to the person supported: death, serious injury or physical harm, physical or sexual abuse, significant pain, intimidation or mental anguish, probable risk of serious harm, loss of funds or property greater than $1,000 in value, or prescription-controlled medications regardless of value, or through supervision neglect, harming a citizen in the community, or engaging in criminal acts resulting in arrest and confinement. Wrongful conduct in this category is of a nature serious enough to call into question whether the offender should be entrusted with the care of a vulnerable person. A final investigative report reflects that the evidence supports that the identified staff acted in accordance with this definition. Class 2 events. The wrongful conduct affecting the person supported constituted abuse, neglect, or exploitation, or misappropriation of money or property, but resulted in minimal or no physical harm or injury, pain or mental anguish, minimal risk of serious harm, loss of funds or property of up to $1,000 in value, or in violation of plans of care with minimal or no adverse consequences. Wrongful conduct in this category is of a nature that disciplinary action and/or additional training may be reasonably deemed sufficient to address. A final investigative report reflects that the evidence supports that the identified staff acted in accordance with this definition. Due process is the legal requirement that the state must respect all legal rights that are owed a person. It balances the power of law of the land and protects the individual person within the power of the state. It is important to note that with the new REM system, staff substantiated for a Class 1 event or staff that have been substantiated for 3 Class 2 events within a rolling 24-month period will have the ability to appeal the substantiations by either file review or administrative court hearing. More information on due process can be found on the DIDD website. Now let's talk about dignity of choice. Dignity of choice is the right of a person to make an informed decision to engage in experiences of his or her own choosing, which are necessary for personal growth and development. Supporting dignity of choice means honoring a person's right to make choices and engage in activities that may involve risks associated with these types of choices and activities, and committing to assist the person to identify, consider, and implement strategies to mitigate the identified potential negative consequences of these choices. Per Center for Medicare and Medicaid Services, dignity of risk is the idea that self-determination and the right to take reasonable risks are essential for dignity and self-esteem and should not be impeded by caregivers concerned about their responsibility to ensure health and welfare. Tolerable risks are the risks a person is willing to accept and take given their goals and choices and preferences and the risk mitigation strategies that can be applied to avoid potential negative outcomes. Effective risk management processes allow a person to make an informed decision about which risks are tolerable. Provider and individual staff persons who provide HCBS should not be held responsible if, in spite of appropriate supports and implementation of appropriate and reasonable risk mitigation strategies, an untoward event occurs. Let's talk about an example of dignity of choice. A person desires to have alone time without any staff present in their home. The person clearly understands the risks associated with cooking or operating kitchen devices and how to respond should there be a fire or other emergency. The person is aware of how to contact staff or a natural support if assistance is needed during this time. The person has arranged implementation of assistive technology to dispense medication and monitor the administration of the medications. Failure to provide any support and/or education related to the independence in the home, such as not exercising the evacuation plan in case of a fire, testing the emergency contact system, addressing special needs, or assistance with ADLs prior to implementation of alone time would not be an example of dignity of choice and would be considered neglectful.
DIDD, TennCare, MCOs, and stakeholder group of 1915C, Employment and Community First Choices, and Choices providers have worked diligently on this development of the REM system in an effort to provide a comprehensive and aligned process for the reporting and prevention of reportable events. This collaborative effort has brought together the best aspects of the supports from each of the entities involved and serves to provide supports that will enrich the lives of the individuals that we have the honor of serving. For additional information regarding the REM process, please visit the DIDD website at www.tn.gov/DIDD/REM. If you have additional questions, please contact your event management coordinator.